Hello, and thank you for joining this OncLive PER exchange titled Advanced Breast Cancer Challenges and Opportunities. We continue to make tremendous progress in the field of breast cancer research and developing more personalized strategies for systemic therapy. With expanded use of novel, targeted, and immune oncology agents, the landscape of therapy for advanced breast cancer is changing. However, several questions remain unanswered as to which approach will be optimal for a given patient. In this OncLive peer exchange discussion, I am joined by my panel of colleagues. Together, we will look at the newest data, including those from San Antonio Breast Cancer Symposium 2019, the annual meeting that will shed light on therapies for advanced breast cancer, how they are evolving, and the implications for clinical practice. I am Debu Tripathi, professor and chair of the Department of Breast Medical Oncology at the University of Texas MD Anderson Center in Houston, Texas. Participating today on our distinguished panel are Dr. Adam Brufsky, professor of medicine and associate chief of hematology oncology at the University of Pittsburgh School of Medicine, and co-director of the Comprehensive Breast Cancer Center in Pittsburgh, Pennsylvania. Dr. Ian Kropp, associate chief of the Division of Breast Oncology at the Susan F. Smith Center for Women's Cancers and associate professor of medicine at Harvard Medical School in Boston, Massachusetts. Joyce A, chair of cancer research at Baylor Salmons Cancer Center, Texas Oncology, and U.S. Oncology Network in Dallas, Texas. And Dr. Hope Rugo, professor of medicine and director of breast cancer oncology and clinical trials education at the University of California, San Francisco, Helen Diller Family Comprehensive Cancer Center in San Francisco, California. Thank you so much for joining us. Let's begin. I want to start off with discussing hormone receptor-positive breast cancer. The landscape for advanced disease has changed rapidly there, with CDK inhibitors now being used commonly in first and second line therapy, and we've recently seen data showing that there's actually a survival benefit. And so the next generation of questions to ask include things like who will respond best, and also an important one is, should there be patients who receive chemotherapy initially? We know that the receipt of chemotherapy may influence outcome to subsequent CDK based therapies, but it's critical to look at might there be patients who should start off with cytotoxic treatment. So to that question, Hope, I would like you to discuss some of the key findings that emerged from San Antonio this year.
You know, one big question, as you mentioned, is the effect of chemotherapy in metastatic disease and your then subsequent response to endocrine therapy. And certainly in some places in the world, and some physicians have thought that starting with chemotherapy might be better because you would debulk the disease. But with the advent of CDK4/6 inhibitors, we have a relatively less toxic combination therapy with these dramatic survival benefits that we've seen in two different major meetings this year. So one of the questions that came up, and actually these studies, of course, started before we knew anything about the survival benefit, was whether or not you would be better to be treated with an endocrine therapy plus a CDK4/6 inhibitor or chemotherapy in the metastatic setting. And actually at ASCO this year, we saw data from Young Pearl, which was a premenopausal investigator-initiated study in Korea, very well done. Took patients who had had a little bit of chemotherapy, tamoxifen before, were premenopausal. They went on ovarian suppression and aromatase inhibitor, and then palbociclib versus getting, so a triplet therapy versus getting capecitabine. And what that study showed, relatively small study, was that patients actually did better on the triplet with palbociclib and the aromatase inhibitor and ovarian suppression. And actually, subsequently, they showed that there was better quality of life in those patients as well. So that was kind of encouraging data. And then we saw the much larger Pearl study through the SOLTI network through actually HICAM, in Spain, where they randomized patients who'd actually relapsed within a year of adjuvant aromatase inhibitor therapy or within a month of receiving it last in the metastatic setting, and they could have had prior chemotherapy, and actually about 3/4 of those patients had received chemotherapy and several lines of treatment, so they're very heavily pretreated. And then those patients were randomized to receive first exemestane and palbociclib versus capecitabine. About halfway through the trial, they got impressed with the ESR1 mutation data, and they randomized people to receive fulvestrant and palbociclib versus capecitabine. And what's interesting in this group of patients is they showed absolutely no difference in terms of outcome between the two arms. Their hypothesis was that if you had hormone receptor-positive disease, you'd do better on the CDK4/6 inhibitor combination. But in looking at that data, it's actually very interesting. The patients who received capecitabine had a median PFS of 10 months, which in pretreated metastatic disease doesn't match any other trial. So it was, for some reason, people did really well on capecitabine. And then the interesting thing is the fulvestrant-treated patients and exemestane-treated patients did about the same, and it didn't really matter whether they were ESR1 wild type or not. So it's an interesting analysis, doesn't really fit into our sort of ideas. And then but it does fit somewhat nicely into PALOMA-3, where patients who had prior chemotherapy, which was about a third of those patients, had a much shorter progression-free survival on fulvestrant alone. In fact, in PEARL, the PFS in these really heavily treated patients was better on fulvestrant than it was in PALOMA-3, but again, you're getting into small numbers. But it's interesting, it's half that as if you don't get chemo. So my take home from these is that CDK4/6 inhibitor and a aromatase inhibitor or fulvestrant is really good treatment, and we should do it before chemo, and there's no clear benefit for doing chemo first.
Yeah, I think we've had a couple of trials now that really have been quite convincing, in that regard. And even in the preoperative setting, head-to-head with chemotherapy and CDK4/6 inhibitor and endocrine therapy, no difference in clinical CRs. PAF CRs are very low. So it's really looking, if anything, that the CDK4/6 inhibitors in young PEARL were superior, but at least as good. So I think it's very convincing data that we can really back away from chemotherapy in the frontline setting, unless somebody has true visceral crisis.